So this is, and again, just on a high-profile note in terms of clinical applicability, this was a study with FOLFIRINOX until progression, although it was limited to 6 months. That's how the French designed it. And then FOLFIRINOX with maintenance therapy around 3 to 4 months, going to 5-FU with reintroduction of the oxaliplatin. There's a third arm I'm not going to spend much time talking about because I don't think it has as much relevance in this discussion. But this study was interesting because it showed essentially that a maintenance, I think the way I interpret it, and I'll see what my colleagues think, that a maintenance strategy is feasible. That we can go from an induction, intense, 3-month FOLFIRINOX, 3 to 4 months, and then de-escalate to infusional 5-FU. The one problem with this study was that although the outcomes were very similar, the toxicities seemed to be higher when you do what I call the stop and go of pancreas cancer, FOLFIRINOX 5-FU, and reintroduce oxaliplatin. And it appears that the reintroduction of the oxaliplatin increased the risk of neuropathy. Now, this is not colon cancer, where 5-FU can maintain you for up to 6 months to a year, where the neuropathy of oxaliplatin may have 1 to grade 1. These are patients that get oxaliplatin get reintroduced within 3 months, and that may explain essentially the increased risk of neuropathy. So I think at least the way I interpret this is FOLFIRINOX followed by 5-FU makes sense, and we should consider it very strongly for most of our patients, if not all, when we use FOLFIRINOX. The question that remains is, do we really need to reintroduce oxaliplatin, or should we switch to another regimen at that point?
Can I give you another take on that?
Yeah.
That I would have
Please.
loved to have seen them ask the question of FOLFIRI as the maintenance.
Yes,
because
absolutely.
I think that combination may control the disease for longer and allow you to continue to hold off the oxaliplatin.
And perhaps reintroduce the oxaliplatin
Later.
once the stone's done. Absolutely, I agree.
You know, I think a lot of this is very important, but it's a subtlety for us as sort of disease experts. I think that what I'm seeing time and again by our community partners is they just keep going until the patient pops, whether it's side effects or fatigue or sort of a treat to progression kind of mentality. And I think the theme in GI, at least in colorectal and pancreas, what we're seeing is that after that induction, it is logical to kind of back off. And we are wrestling about what that backing off looks like, but that should be a theme. Is that fairly, if you're responding and you're getting on top of the disease, that yes, you need to develop a strategy for backing off.
I think we have now a reasonable level of evidence to support this and to continue to explore this, because we really need data to help define, but yeah, I think so.
Mm-hmm.
It allows us to take a break. But again, we're still giving chemotherapy, right? We're just not giving the oxaliplatin. So I think it's useful, but you know, you got to talk to the patient every so often. And what does the patient want?
Particularly if you're going to bill them.
And you know, many times patients want to keep at it. You know, some
Yeah.
patients have a lot of side effects. They get all the fatigue and the neuropathy. They want to back off. They want to break. They want to go to Hawaii. But some people want to keep going.
But some
and
of
that's
that
a
is how we
challenge.
present at the beginning, I think, too. If you go into that first visit with a strategy of saying, we're going to get you off the ledge and then see if we can back this off, I think that patient understands that's the norm.
Yeah.
Versus this sort of culture of the battle of
we've done it
cancer
in
and the
colon
war on
cancer.
cancer.
The hill and-
And we have to keep fighting, and there has to be suffering.
yeah.
And I always sort of reflect on the long game for those patients. Is I'm not worried about this Christmas, I'm worried about next Christmas kind of idea. And that gives them a little perspective of what if you say you want to live forever, well, could you keep taking this regimen forever, or do we need to take some breaks?
Again, it's the sprint versus marathon analogy that, you know, amazingly enough, we're having these discussions.
Yeah,
in pancreas
it's a good
cancer.
problem.
We should be happy that we're having these discussions and we're thinking about these issues in pancreas cancer.
But
that
it's
means
a-
we're making a much better difference.
But again, to emphasize the importance of our palliative care colleagues, because they do a very good job of framing that mindset you're talking about. Whereas we're treating, treating versus. I'm comfortable having the discussion
however,
too,
I
but
do
I'm-
think that oncologists are great palliative care doctors when
Agreed.
they take the time to do it.
Yes.
And I think, you know, it's important to involve the palliative care docs. However, you know, I still personally, you know, act as a palliative care doctor with my patient until I think I really need that next level.